Idka. What they have been giving them. The next speaker is Dr. Virmani. He is a well-known diabetologist and cardiologist of Jamshedpur, and he is going to speak on management of severe anemia and heart failure. Dr. Virmani.
Honorable chairpersons and dear friends, can I have the slides, please? Okay. This is the biodata. A patient comes to you in your clinic with history of chest pain. You do an ECG and there are certain ST-T wave changes which are non-specific in nature. You refer him to the cardiologist. Dr. Deepak Gupta does an angiography. Angiography is normal, and he sends back the patient to you, normal angio. You feel happy, but the patient keeps on coming back to you with chest pain. Now, this is a diagnostic dilemma. Should we label the patient as a cardiac neurotic, or should we suspect microvascular angina? The only disclosure I have that I am not an interventional cardiologist, but I know and I am sure that what information I want from the cardiologist, I will definitely ask him. Now, 50% of the stable angina patients who undergo diagnostic coronary angiography, and 10 to 15% of those presenting with acute coronary syndromes have a normal or near normal coronary arteries. Now, this is called angina with normal coronary arteries, and this has been a continuous dilemma right since 73, when it was labeled as cardiac syndrome X, and in 1985 as microvascular angina. It has also been called INOCA and MINOCA, that is ischemia with non-obstructive coronary arteries and myocardial infarction with non-obstructive coronary arteries. It is indeed a black box, and can we open the black box to see what is happening? Is there a coronary microvascular dysfunction, whether it is abnormal cardiac pain sensitivity, endothelial dysfunction, or perhaps a combination of these two? So, what I am going to do in the next couple of minutes is to discuss the coronary microcirculation, classify the disease, pathophysiology, clinical presentation, assessment and management. When we talk of coronary artery disease, it means that there is a stenosis, one or more stenosis in the epicardial arteries, which is more than 50% as compared to the referred to the on the angiographic images as compared to the adjacent vessels. But it does not acknowledge the flow beyond these lesions in the black box or so-called microcirculation. This is what the angiography, the cardiologist sees, and what he does not see is this. So, you can imagine the cardiologist sees only 5% of the coronary tree, only 5%, and based on that we make a diagnosis of either a cardiac neurosis or normal heart. Now, if you look at the circulation, I will not go into details, just remember the macrocirculation, epicardial arteries are more than 400 microns, which the cardiologist is looking at, and the microcirculation, small arteries going down from less than 400 to even less than 100. What I want you to here remember is two things. There is something called fractional flow reserve, and that tells us something about the macrocirculation. And there is something called the coronary flow reserve, which talks of the total coronary flow reserve. When you look at the microcirculation, it is the index of microvascular resistance, which is very difficult to measure. So, what you have to do, you have to remember only two things, the FFR and the coronary flow reserve. Now, On one side, we have atherosclerotic disease in the epicardial arteries. On the other side, microvascular dysfunction. In between is vasospastic disease, and that is what leads to ischemic chest pain. So obstructive, vasospasm, microvascular dysfunction, and they all are overlapping in the myocardial substrate. So what are the clinical implications? It can lead to myocardial ischemia and often mimic obstructive coronary artery disease. There is basically an increase in the coronary microvascular resistance giving to the symptoms. It was earlier called cardiac syndrome X. But remember, it can also occur in the context of other cardiac diseases and as well as in association with obstructive coronary artery disease. And there is now a growing interest in the documentation of coronary microvascular dysfunction in the context of established coronary artery disease, epicardial obstruction. Classified: type 1, absence of myocardial diseases and obstructive coronary artery disease, that is true microvascular dysfunction. Risk factors: microvascular angina, pathophysiology, basically endothelial dysfunction and smooth muscle cell dysfunction. Then we have those associated with common myocardial diseases like hypertrophic cardiomyopathies, dilated amyloidosis, etc. And then we have the classical obstructive CAD, and then we have iatrogenic related, maybe rupture after the PCI or CABG. The first one, type 1, is primary, and these are secondary. Clinical presentation: primary microvascular angina, stable if the dominant effort angina, unstable if acute rest angina. And remember, there is a gender variation, higher prevalence in females. So we are more likely to miss it and diagnose it as cardiac neurosis. Now, the clinical pearl here is when the patient presents with chest pain, this chest pain is longer lasting and there is slower resolution with nitrates. So if you see a patient where the chest pain is lasting for a longer time as compared to the usual clinical classical angina and the resolution is slower as with nitrates, suspect microvascular angina. These are the classical pictures: typical angina, normal ECG, normal coronary angiogram. Now, but before we go to microvascular angina, it is mandatory to rule out vasospastic angina. So you look at the ECG, you look at the classical symptoms, and if there are matching, yes, possibly vasospastic angina. If not matching, vasospastic angina, unlikely. But this is a clinical scenario that you are looking at. So basically, we must know that we have to do a functional evaluation with an acetylcholine provocational test, and we have to do a morphological evaluation with various invasive and non-invasive tests. This is the classic acetylcholine test. You see a constriction here, and you see after giving isosorbate, the constriction disappears. This is a classic case of vasospastic angina. Now, there are certain limitations of acetylcholine provocation test. It has got a high sensitivity and specificity, but then again, compared to the coronary angiography, there are certain problems. You are using contrast media, so it can have renal adverse effects, radiation exposure, bronchial asthma can be precipitated, patient can have complications like VT, cardiac tamponade and shock. So majority of the interventional cardiologists don't want to touch this area. For them, just doing an angiography is their bread, butter and jam. They are happy with that. That is the problem. But in good centers and in good hands, it is a very, it is a safe method and it can be performed carefully in good centers. Now, if you look at the difference, how the patient presents, if there is vasospastic angina, there is first of all perfusion heterogeneity, then metabolic alteration, then diastolic function, regional dysenergy, ECG changes, and patient comes to you with angina. On the other hand, if the patient is having microvascular angina, there are initial ECG changes, angina, and then it leads to perfusion heterogeneity. So what are the investigations? We have the exercise or dopamine echo, we have the transthoracic Doppler echo, and the acetylcholine and adenosine test to find out the vasospasm and hyperemia. Now, another clinical pearl, when you are doing echo, if the patient is having epicardial coronary artery disease, there will be regional wall motion abnormalities, and the distribution of myocardial ischemia is usually diffuse. In microvascular angina, the distribution of myocardial ischemia is patchy. There are no regional wall motion abnormalities. So the absence of regional wall motion abnormalities again gives you a hint that this is microvascular angina. And this is basically you looking at impaired vasodilatation and impaired vasoconstriction with the various tests. So what are the assessment morphological evaluations you are going to do? The most important is the invasive one, and that is using the Doppler wire coupled with a pressure thermodilation device to measure both the coronary blood flow and the coronary vascular resistance. And then we have the non-invasive investment with the positron emission tomography, and the CMR, the cardiovascular MR is also coming up. Now, this is the classical one. You see a defect on the myocardial perfusion, but here there is a abnormal global myocardial perfusion, and the coronary angiography was normal. So again, I stress on the fact, while doing an echo, if there is regional wall motion abnormality, is coronary obstructive disease. If there is no RWMA, then look for microvascular angina. Now, I talked about two things that I told you to remember initially, the fractional flow reserve and the coronary flow reserve. The fractional flow reserve is specific for epicardial disease. The cutoff is 0.8, which means anything less than 0.8 is inducible ischemia, more than 0.8 is no inducible ischemia. And the cutoff for the coronary flow reserve is approximately 2, that is, which is a borderline, so they describe the take cutoff as 2. So how do you diagnose? If the FFR is less than 0.8, it is inducible ischemia, so it is flow limiting stenosis. Then you look at the coronary flow reserve. If it is normal more than 2, it is preserved microvascular function, and if it is less than 2, it is coronary microvascular disease. On the other hand, if the FFR is more than 0.8, it is non-flow limiting stenosis. Again, you look at CFR, if it is more than 2, again preserved microvascular function, and if it is less than 2, it is non-flow limiting, it is coronary microvascular disease. Both are non. And this is the ultimate algorithm, and you can then diagnose epicardial coronary artery disease, microvascular angina, or both microvascular plus vasospastic angina, or no cardiac chest pain, patient is normal. So it's a very good way to do it, and the main thing is to look at the CFR after looking at the FFR. Medical treatment, all of you know, short-acting nitrates, beta blockers, calcium channel blockers. Now, long-acting nitrates have very limited efficacy in the microcoronary circulation. Other drugs, ranolazine, avabradine, nicorandil, trimetazidine. I won't go into details, all of you know where to use when. There are additional drugs which are needed in these patients, like the RAS blockers, statins, xanthins, and estrogens, etc. Then we have non-pharmacological treatments like spinal cord stimulation and enhanced external counterpulsation. Then, of course, to give you the final message, which drugs this patient should be optimally taking to prevent recurrent angina: aspirin and statins, class 1B evidence, beta blockers 1B, calcium antagonists 1B. AC inhibitors or nicorandil 2B, B, and xanthin or neurostimulatory techniques, again class 2B, level B. So, therapeutic approach, the specific goal in the treatment of stable microvascular angina patients is to decrease the anginal symptoms, improve the quality of life. And after having used all this, the main aim is that you must have a pathophysiological approach in the treatment. And what is that? You should try to affect myocardial oxygen demand, microvascular spasm, or abnormal vasodilatation, or perhaps all the three together. That should be your aim, ultimate aim. Now, this is a recent article published in the Journal of American Cardiology this year only, about a month back, and look what they are saying. There is a paradigm shift. Non-epicardial coronary causes are more prevalent than flow-limiting stenosis, and we never knew this. We always thought angio is normal, forget. Assessment of ischemia that do not delineate abnormal coronary angiographic findings should not necessarily shift diagnostic and therapeutic considerations to non-cardiac causes of angina, but rather look at microvascular angina. That is very important. It is very important before labeling the person as cardiac neurosis or looking for non-cardiac causes, do a functional assessment of the coronary circulation. And such additional testings can be done wherever needed. Now, a conservative approach to management, you need to have a non-invasive approach, then lifestyle interventions, goal-directed, multifaceted medical therapy, and this is all evidence-based and can be used. So the key messages that I want to give you today, friends, is angina with evidence of stress-induced myocardial ischemia, but normal coronary angiogram is called microvascular angina. Less than 2 on adenosine-induced hyperemia. So hyperemia, you are inducing with the adenosine. If it is less than 2, it is microvascular dysfunction. There is no spasm. You have to rule out vasospasm on acetyl provocation before coming to that diagnosis. Exclude out other causes of the cardiac diseases that I talked about, like cardiomyopathies, amyloidosis, and etc. Underlying pathophysiology is heterogeneous, so non-uniform response to different diagnostic tests and therapeutic approaches. Existing guidelines focus on symptom management, and current treatment is reassurance. The treatment. This appears to be insufficient because the ischemia-related events are going to be recur again and again, and the patient is going to come to you again and again. So it is of the utmost importance that the management of this condition is basically patient-centered and focused on the use of adequate anti-anginal medications and on the modification of lifestyle and risk factors. Thank you for a patient hearing.
Excellent presentation, Dr. Virmani. It's actually whenever a patient comes to us with chest pain and he has positive stress test, the only way to rule out is to do an angiogram. So once we do an angiogram, then we alert with 2 entities. When it's a normal angiogram, then either it's a non-cardiac chest pain or it's a microvascular angina. So this is the usual common practice. But by your lecture, we must understand that this entity also exists. Something like what we have seen, heart failure with preserved ejection fraction. Something like that. So
see, that is why I said there is a paradigm shift in thinking. We should not remain static. Medicine is advancing rapidly, and we should be able to change ourselves to new learnings that are coming up. Now, if your angio is normal, you cannot be guaranteed say that there is no cardiac problem. Please note this important fact. If you have to do a functional and a morphological evaluation of the microcirculation before labeling the person normally as far as the cardiac thing is concerned. That is an important thing, and that is why I said okay, this is the information I want from the interventional cardiologist. If your angio is normal, I want to know the FFR, the CFR. Have you gone for an acetylcholine provocation test? Have you ruled out vasospastic angina?
see again,
And
cost.
then only then we will think of non-cardiac causes.
Yeah, cost becomes a constraint, and again the complication of the procedures by giving acetylcholine, again that becomes a constraint. Ultimately, we are left with the same medicines. If it's a normal coronary, also we have to give nitrate, we have to give beta blockers, we have to give nicorandil. So at the end of the day, we have the same medicines, whether it's a vasospastic with normal coronary or it's just a normal coronary.
You are right. If the angio is normal and you write the same anti-anginal medicines, one of your colleagues is going to get up and say, angio normal hai, kaise dawai de di aapko? Now let me tell you a small story. It's a wonderful story. I was giving a talk in Delhi to some of the interventional cardiologists. So I asked them, how many of you sitting here think that you have placed an unnecessary stent? not a single hand raise. And then I asked them, how many of you think your colleague has put in an unnecessary stent? 40%. So that is happening in the world of cardiology. So we have to now change. You must learn and listen new things now.
But from our side, we want to say that we do angiogram only when it is needed.
Well,
Please believe us.
I'm not blaming you. Angiography is a must to rule out obstructive coronary disease. I'm not snatching your bread and butter. I'm giving you that bread and butter, but I'm asking you to do more and give me more information. So I'm giving you jam also along with bread and butter. Don't worry.
Okay, thank you, sir. Lot of interactions. Sir, please wait. Dr. Virmani, sir, please wait. May I request other speakers to please join on the dais? Dr. Puneet Saxena.